Good morning. Welcome to Grand Rounds. Hi, I'm Laura Zakowski, Vice Chair for Education, and I'm going to just briefly kick off Grand Rounds today by reminding you that in 2 weeks we have Education Day, and we'll start Grand Rounds at HSLC and follow that with awards, with workshops, with lunch, posters. Please come on over in 2 weeks. That would be great. We're having a speaker talk about bias in evaluations. So Dr. Abraham. So I want to also introduce Dr. Matt Cherpek, who's with the Division of Pulmonary Medicine and Critical Care, and he will introduce our speaker today.
Very much. Hello, everyone. And just a reminder that at 9 o'clock after the formal Q&A, you are free to come up and talk to Dr. Liu afterward from 9 to 9:30. So it's my great pleasure today to introduce Dr. Vincent Liu. Dr. Liu is a senior research scientist at the Kaiser Permanente Northern California Division of Research. He directs the Systems Research Initiative and is also the Regional Director of Hospital Advanced Analytics in Kaiser Permanente Northern California. He has led and served on committees for the American Thoracic Society, the Society of Critical Care Medicine, the National Quality Forum, and the National Institute for General Medical Services. Clinically, Dr. Liu is board certified in internal medicine, pulmonary medicine, critical care medicine, and clinical informatics, and practices pulmonary and critical care medicine. Dr. Liu's work focuses on the intersection of sepsis, acute severe illness, informatics, and healthcare delivery, with the goal of building toward a learning healthcare system. He has an impressive track record of funding, including several R01s and R35, as well as foundation grants. Vinny is widely recognized as an expert in the fields of sepsis, predictive analytics, and informatics. In addition to his professional talents, he's a great collaborator and a wonderful person. Please join me in welcoming Dr. Liu for his talk entitled AI, Augmented Intelligence at Health System Scale, Promise and Pitfalls.
Thank you, Matt. Can everyone hear me okay? All right, excellent. Well, it's really a pleasure to be here. I have good memories of Madison, having been out here for some travels with Epic. And then, of course, Matt and I, we were just reminiscing. We've known each other probably for 10 years and work in similar spaces. So I get to see Matt in lots of places, but it's really nice to, join him here in his lab as well as in the university. Today, I'm going to be talking about AI and the way that we think about it, which is our augmented intelligence, some of the experiences that we've had at Kaiser Permanente in Northern California. Okay, these are some of the funding sources that help to support my research. So I think without a doubt, most of us would say that the year 2023 was the year of AI. And in January, you see lots of review articles from the prior year. And here are just some. We are unprepared for the AI gold rush, the year AI ate the internet. We have tech giants, talking about groundbreaking advances. Bill Gates says the age of AI has finally begun. Then there are the worrisome things. This was the year of AI. Next year is when you should worry about your job. And then, of course, AI is like nuclear weapons. This game-changing technology that the world both will stare at in wonder, but also in fear. We have new journals like New England Journal of Medicine AI. And then for those of you who haven't watched John Oliver's take on AI, I recommend you do so. So there's just been extreme interest in this topic in 2023 related to the release of ChatGPT. And I think there's been a lot of questions about what is the impact, what are the disruptions, and how will this play out for all of us, no matter where we are as citizens in societies and communities, or as patients, or as how we're affiliated with healthcare at large. I'm going to talk through kind of 3 different phases, a more historical phase, talk about some of the work we're doing at KP, and then think towards the future. What this initial experience in this age of AI teaches us about how we can best position ourselves. So when we talk about AI in healthcare, actually, AI has been around for a long time. This is work led by Dr. Ted Shortliff, who's one of the kind of fathers or founders of the field of informatics. He was at Stanford at the time. This is the 1970s. And they created a system called MySyn. And here on this dot matrix paper, they say MySyn is a computer-based system developed at Stanford over the past 3 years to provide consultative advice to physicians on the diagnosis and therapy of infectious diseases using both clinical data and the judgmental knowledge of experts to improve the effectiveness of medical decision-making with regard to clinical therapeutics. And it may be a model for those designing other AI programs. So again, this is more than 50 years ago. Already AI had entered into healthcare. So what do? Well, they pull together what is now thought of as kind of an expert system, which is just a series of very complex rules that roll up in different structures. So here on the left, you see just one, these are a couple rules, Rule 37, Rule 145, that talks about characteristics of a culture or a potential pathogen or the results of a diagnostic test. These rules then are pulled together in this context tree, which kind of helps to guide this system in decision making, and then ultimately into these more complex reasoning networks. This was the work of a bunch of investigators who together were kind of encoding expert knowledge into these rules and then putting them into these reasoning systems. And what was the result? Well, this paper was actually published in JAMA in 1979, where they took MySyn and compared it to faculty, residents, and fellows. And the faculty here were infectious disease faculty. And what did they find? Well, MySyn outperformed every human. So when it came to here on the leftmost column, the number of cases in which the therapy was rated acceptable by a blinded evaluator, it was 65% for MySyn, which exceeded everyone, including students and residents, who are at 30 and 45%. And then also when it came to safety, here on the rightmost column, the number of cases in which therapy failed to cover a treatable pathogen. In other words, did it miss anything? That was 0. So here we're looking at a 50-year-old specimen of healthcare AI, one which outperformed all of the kind of expert faculty at the time, and one which serves a clinical need that kind of still exists today. Am I missing anything as I try to decide what the appropriate treatment is? So does it address a clinically significant challenge in healthcare? Yes. Did it include up-to-date knowledge about treatment? Yes. Did it address contextual and clinical factors that impact therapeutic choices? Was it proven to outperform human comparators in real-life examples? And did it explain to users why it arrived at a certain conclusion? In other words, it was not a black box. So it fulfilled all of these criteria by which we would say, oh, this is a system that makes sense, is proven to work, and that should be an aid to clinicians. And yet, this example, which is written about in many history books, never ever once was applied in bedside care, never made the leap from an AI system into real care. And why was that? And Ted Shortliff wrote, as he was looking back, we need to realize that the practical influence of AI in medicine in real-world settings will depend on the development of integrated environments that allow the merging of knowledge-based tools with other applications. So this is saying, essentially, they couldn't integrate it into the place where people were working, right? Today, for us, that's the EHR. Back then, there wasn't really even an EHR. So they couldn't integrate it both to feed the information into the system, nor to output its results and recommendations in a seamless way. And then the second, I think, is our ability to influence the delivery of healthcare will depend on the vision and resources of leaders who understand that medical practice is today an inherently information management task and must accordingly be tackled and supported as such. So he was kind of prescient in altering kind of the way that we approach medical care into this information management task, and that we needed to set up the systems and the leadership in order to be able to advance that goal. And I think these continue to be the challenges and will continue to be challenges into the future related to how we can bring AI most effectively into clinical care. Okay, well, let me talk a little bit about where I'm coming from, Kaiser Permanente, to give you a background. So Kaiser Permanente, our mission is we exist to provide high quality, affordable healthcare services and to improve the health of our members and the communities we serve. Kaiser KP is mostly in the western part of the US, but we also have regions in Georgia, mid-Atlantic states, Colorado, and a couple other folks. In total, the health system serves 12.6 million members. And what distinguishes it from other kind of health systems is that we're highly integrated, which means that the health insurer, who also owns the hospitals and employs a number of staff in IT and nursing, is in a mutual exclusivity partnership with medical groups that serve each region. So in most of the regions we have, KP patients are seen by medical group doctors, and medical group doctors only see KP patients. What that allows for is kind of this full degree of integration. So patients have one medical record number across all of their care, whether it's from a clinic, from a hospital, from a SNF, from a pharmacy, and most of that information is available. This gives you a sense of kind of the scale: 100 million prescriptions filled, 1 million mammograms a year, and 705 million visits to our online portal for patients, 44 million secure messages sent to providers, 97 million lab test results viewed online. So, but KP has actually been engaged in this advancement of AI as well for a long time. So this is the New York Times obituary from the founder of the division where I work, the Division of Research, about Dr. Morris Collin. And Dr. Morris Collin was a kind of also one of the fathers of informatics. And so here it says, by the early 1970s, with the help of federal funding, this database, which he was creating, had grown to hold information on several million patients, becoming a valuable tool for tracking individual cases, but also identifying broad trends, and essentially that kind of using computers to shape the way that we provide care became the basis of this field called medical informatics. And so I like to say at KP, data science or AI is really in our blood. It's kind of in part of the way that we think about how we link together data and computers into bedside care. And it even goes further back. I sometimes like to say it's in our origin story. So Dr. Sidney Garfield was the first physician of KP who partnered together with Henry Kaiser, who was an entrepreneur and industrialist, in order to provide prepaid health insurance, prepaid medical care to all of the workers who were in the shipyards. And that was kind of the foundation of the care that's provided today. In 1970, in Scientific American, he wrote, medical care in the US is expensive and poorly distributed. What we need is an innovative system in which the sick are separated from the well. And so in this article, again, more than 50 years ago, he says, and this is a little bit hard to see, but in the 1900s, which is that panel all the way to the left, he says, the only patients up top who could come to get healthcare were those who were very sick. And they would go to the doctor, maybe they would go to the hospital, and they would either be cured, they would have custodial care, or they would die. By the 1930s, there was some additional complexity in the system. So, you could get an EKG or an X-ray. And so the patients who could be served by this system were both the sick and the early sick. By the 1970s, when he was writing this, he said, oh, care has exploded. Now the patient case mix that we're serving are the early sick, the sick, as well as the worried well. And now kind of they're moving all over the place. And that's what he said was the challenge, is that if we don't have an effective system to separate the sick from the well, we will be overwhelmed, right? Like the gate, they will open the doors and people of all types will come in and we won't be able to distribute them to the right venues of care. And so he kind of produced this model. And I've taken the liberty of putting some additional text here. So he said, our population is going to include the well, the worried well, the early sick, and the sick. And we might have, again, this is the 1970s, but I think continues to hold. We might have 4 major venues or domains of healthcare provision: diagnostic testing and referral service, health counseling and education, chronic disease management and prevention, and then hospitals and acute care centers. And what he said was, and was again really prescient, was that what we need is a computer at the center. So again, 50 years ago, he said, our problem is we don't know how to distribute these patients in an effective way. The only way we're going to accomplish this is by having a computer at that center. And that computer center, which we've now been upgrading decade over decade, now will be upgraded by everything we see in AI, will be to proactively separate the sick from the well, direct patients to highest value care, and ultimately facilitate ongoing learning and improvement. And I would argue that this continues to be the direction that all of the efforts that we're working towards are aimed at, which is really, can we proactively, effectively distribute patients to the right venues of care so that we can prevent them from having worse outcomes. And that's shaped a lot of the kind of approach that we've taken to AI at KP. And I like to think of it as in the title, AI is augmented rather than artificial intelligence, because augmented intelligence places people, patients, clinicians, and communities at its center rather than algorithms. And that's really important because the algorithms are obviously foundational. They continue to be upgraded. But what really matters is kind of this overlap or handshake between data science and delivery science. So data science might be our researchers, our predictive modelers, our AI specialists, infrastructure teams, and platform IT. And our delivery science is the process by which we take an effective intervention and be able to deploy it at scale. And those would definitely include our operational leaders and our clinicians. And when we can achieve this very good handoff and handshake, then we're going to be effective in using whatever technology or the computer center of care. In this case now, from today forward, these really rapidly advancing technologies that we're seeing. Okay, what are some examples of this? And for those of you familiar with Matt's work, I think this will look actually quite similar. This was work that we were doing at around the same time. This was the building of something akin to eCart, Advanced Alert Monitor, which was designed to predict patient deterioration in the hospital. So the outcome was patients who would have an ICU transfer or an unexpected death within the next 12 hours. These are some of the variables that went into this. At the time we were building this was really hard, because that was like 12 years ago. Now this is trivial. These data are available. This was built before the EHR was even, before like the fully functional EHR was there. And a lot of this work was done really by my mentor, Gabriel Escobar. And what was the goal of this? Well, it was to take real-time, this just seemed like a fantasy at the time. We would take real-time data as it came through the EHR or whatever system. We would feed it into this algorithm, and then we would feed it back into bedside care through an alert. And again, that was kind of, as amazing as it seems, this was actually difficult. And the principles for this development were really human-centered ones, right? This is not really about the algorithm. The algorithm is important as a starter gun, as a kind of crystallizing focus, as some degree of precision around risk. But really, this is about achieving patient goal, human goals. So first, to identify highest risk in patients for deterioration. Second, very dominant, was to respect patients' goals of care. Because we know in our system, between 20 and 25% of patients who are hospitalized do not want life support therapy, like life-sustaining therapy, like to be shocked or have their chest compressed. And so even patients who are deteriorating Not all of them are going to want more aggressive or invasive care. Also to give clinicians enough time for action, and then ultimately to minimize false alarms. So again, really, we knew that this will be dead on arrival. If there's too many false alarms, it will not be effective if we don't give our clinicians enough time for action, and it will not be ethical or aligned with our patients' goals if we're not actually considering pathways to get them on the off-ramp from escalating therapies. And again, these are some of the things, educational materials that we had here. So for example, this is kind of the workflow. There's a time zero, but if we give it to the alert early enough, we tell our clinicians walk, don't run, right? Like you can finish lunch and then go see this patient. The goal was not to have an emergency where everybody had to rush to the bedside, but we used a virtual nurse who would do an initial chart review. They would call the local RRT nurses. This is because we have 21 hospitals across our region. So the primary reviewer would be a regional virtual staff. Then there's communication with the primary bedside nurse, with the physician. They would communicate a plan. If a patient had a certain comorbidity level and received an alert, it would trigger an automatic consult to palliative care or to the social worker so they could make sure they understood goals of care. And then, if they were discharged, they would follow up with some wraparound kind of services. We also learned how to begin to communicate about risk-based alerts. So when we talk to patients, they did not want to hear a big data model is predicting how poorly you'll do in the next 12 hours, or an advanced computer system is monitoring you, or algorithms show that your risk of requiring the ICU or dying is not a shock, right? But there are some, again, if we're talking artificial and not augmented intelligence, there are those who say, oh, tell the clinician, this is a 33.2% chance. And most of us would be like, that's absurd. So not that, more, we've been monitoring your labs, we will be monitoring you and reviewing your progress. We're gonna have the social worker come talk to you about life care planning. So again, at the time we did this, it was a lot of uncertainty about whether this would work. And whether we had the capability to do so. I remember the first time I met with our national leader of our EHR. He chewed out me and Gabriel because he was so upset that we wanted to put this system into the EHR and how challenging it was going to be. But we pushed ahead, and what I told Gabriel, I remember, before we began this study was essentially this is kind of our Trojan horse. Like it may not work, but at the end of it, we will now have a platform to begin to implement these tools in real time. And we'll just have to kind of, cross our fingers. Fortunately, it worked, and it was produced statistically significant benefits for our patients. So this is the publication. I think it was in 2020. This shows the stepped wedge implementation of this tool across 19 of our hospitals. 2 had gone first in pilot, so they were excluded. But what's amazing, I just look back at some of this work that Gabriel led. I mean, the rollout was over 3 years to ensure that there was adequate amount of sample size and that enough of each hospital was serving as its own control over this kind of time period. But this is a little bit of a complex table, but it was associated with a 10% roughly decrease in ICU admissions, and somewhere between a 10 and 15% decrease with death within 30 days. So there was a lot of concerns. First, that it would increase admissions to the ICU, because doctors wouldn't know. If you say this patient's at high risk, they would then default to saying, oh, we better escalate them to the ICU. But what we found was it actually decreased ICU admissions, and then actually decreased mortality as well. It also increased goals of care documentation to ensure that patients were not having escalations in care that they didn't want. So this was just a bit of really, really good news, and kind of has been one of the really important platforms upon which we've built some of these other tools. And I'll review some of those. So this is an example where shortly after we put in a readmission risk score that targeted patients at medium and high risk for readmission, those who were at 25% or higher within the next 30 days. And this shows you kind of like we looked at the secular trends all the way back, going back to 2010. There's an implementation period, and then this was the completion of the implementation. It didn't have any impact on low-risk patients because they weren't targeted, although we've subsequently done a trial in these patients or a subset of these patients who we think are at higher risk and have been able to show that we've also been able to bring down readmissions. What's really important here is this score, which again wasn't that simple because was relatively simple because we built it even before the EHR was robustly available. This score is paired with a workflow, right? It doesn't live alone. It gets integrated actually into another group called the Transitions Program, and they do proactive outreach to patients. They try to make sure that after discharge, the patients remain connected. So these are, again, kind of like building off this principle that for the future of AI, we both need the impressive algorithms and computing systems and integrated environments in which we can ingest data and display it, but then we really need that to be directed through humans, clinicians. We need patients. So a lot of times, this also harkens back to something called the fundamental theorem of informatics, which is something that was posited by Charles Friedman, which essentially says human or doctor with a computer is going to be better than doctor alone. We have to do it the right way. And this also kind of now leads to this phrase like, AI is not going to replace doctors, but doctors who use AI will replace those who don't, right? And again, all of this speaks to if we can integrate these systems together and do it effectively, we will achieve better outcomes, better efficiencies, better effectiveness, hopefully better safety than I think if we try to do it alone. And yet we can't let the computer dictate how care is provided. That will fail. So as we've pulled back and tried to build a framework for understanding what organizational competencies do we need, and again, this is prior to the year of AI, but we've been building this, it's kind of come down to this. And this is not the prettiest table, but I'll walk you through it, and it's informed by kind of some of the examples I've given. We have three major cores, I would say. There's a data science core, there's an operational integration core, and then there's a technology enablement, right? So we have leads that work in each of these domains. And then we have a variety of competencies. And here I've tried to label, which of these cores is primarily responsible for that area and which might be secondary. So let's say if we want to understand, does this model perform well? Like a vendor comes to us or someone develops a model and they want to say, is this performant? Well, that's really something the data science team will evaluate, whether that's AUCs or positive predictive values, sensitivities and thresholds, looking at all of those. Another piece of this is to make sure that this thing gets deployed seamlessly where people work, right? That might be one of the most important things. Even a lower performing model, if it's integrated well, will be actually very successful. So that's kind of our technology enablement team. Where is the data lake? Where are the data streams? Where does the algorithm run? Is an algorithm simple, like a tree or a logistic regression? Or is it something more complex? And do we need, some advanced computing to execute? And then finally, kind of another core competency is just workflow integration. What do the playbooks look like? What is our educational campaign? Who are the champions? Have we secured the endorsement from all of the relevant chiefs groups who are going to touch that? So this is what I would say we've been working on for the past, 5 or 7 years kind of building towards. But we've come to understand, and I think the field has, that there's more competencies now if we're really going to do this at scale, or if we're going to build a pipeline. So one thing that lots of folks are focused on is model bias and fairness. So I think of the bias as the performance of the model across subgroups, right? Is the algorithm itself generating differential performance in subgroups? And there's a bunch of domains that can be measured on. And I think of fairness as what is the downstream consequence of us putting this model into practice, right? Because you could actually use a biased model and do it in a fair way. I think you can also take a non-biased model and roll it out in an unfair way. So some of that is kind of in data science. A bunch of that is also in operational integration. And it involves not only detection before we put the model into production, but also downstream monitoring to look at unintended consequences. A lot of folks are thinking about model intelligibility. What degree of information do we have to give to a clinician or the end user, whoever that is, for them to explain or to interpret or to have an adequate degree of, I think, transparency and trustworthiness about a model? So again, some of this is kind of technology. What do we need to show? And some of it is data science. Yesterday, we talked in one of the groups a little bit about this. The risk and regulatory environment is becoming really a major driver in how we approach this. Things from the FDA, things from the White House executive order, the EU, NIST, the ONC, all of these. For those of you in this space, every week now we're reading these documents, guidance about what we should do. Ultimately, also outcomes and value. These things are not cheap to develop, to implement, and to sustain. So what is the downstream value that we're going to get? And do they move the needle on patient outcomes? Are they more hype than hope? And we need to actually rigorously evaluate those. Model maintenance, right? So unfortunately, these are not set it and forget it. They actually probably require very standard service schedules like you would for your car. You every several thousand miles or number of uses or time elapsed, we're going to have to go back in, check performance, and do a tune-up. Where we've not done well is community input. How are our patients feeling about these models, and how should patient priorities help us understand how we do this most effectively? And then ultimately, a thing that I think everyone's focused on, especially at a university setting like this, is workforce upskilling. There will be fundamental changes to the way that we practice medicine, that we deliver healthcare, that we conduct biomedical science into the future. And fluency with the skills and the outputs and the dangers of some of these technologies is going to be essential. So here are some other examples as we've kind of begun to build this pipeline out from work from my colleagues. Mike Kuznowitz also worked with Dr. Escobar. They built a simple score to examine the risk of early onset sepsis. So this is to curtail the use of antibiotics in newborns. And so what they showed was that by using this calculator, they could tremendously decrease, roughly by more than half, the use of blood cultures in newborns, as well as the provision of antibiotics by about 50%, which is incredible. Because with no increase in the rates of infections among newborns. And this model is endorsed by the American Academy of Pediatrics and has been used around the world. I think it has like 5 variables. So when you begin to bring some quantitative assessment to a process which has been built historically over time, we have the capability, hopefully, to not give antibiotics where unnecessary. Doctors Volk and Mike Silverberg built a model to identify the risk of incident HIV infection. So among patients who did not have HIV, what was the risk that they were going to acquire HIV? And they used it because it's a recommendation from the USPSTF to counsel and to start pre-exposure prophylaxis for these patients. who are at high risk for HIV infection, because pre-exposure prophylaxis is incredibly effective. And so we deployed this with them in the EHR in a randomized fashion. And here you see kind of, this is the cumulative incidence of PrEP linkage, whether they got a counseling linkage or a clinic visit linkage. And you can see there was an increase based on the EHR secure messages. This was not statistically significant, but when they stratified it by those who were HIV providers versus those who weren't, it was very, very effective among those who already had the experience there. Again, this speaks to, it's the algorithm, but it's the algorithm paired with the right education and the right implementation. In fact, interestingly, in the non-HIV providers, meaning their panel it didn't have many HIV patients, it actually decreased the incidence of PrEP linkage. So there's a lot more work to be done here. Dr. Honor Shin is currently testing a suicide attempt risk prediction model for a regional virtual mental health intake. So patients are referred for mental health into a virtual regional intake where they're outreached to by a regional staff. And so the question she has is whether EHR-based risk prediction model could help actually make that process more effective. These are some of the things that go into the model. We validated it in our region. We looked at its performance across racial ethnic subgroups, which was generally comparable. And then what she has done is built this workflow so that this Connect to Care, C2C clinical manager, if they get the suicide risk score triggered, they will then do proactive outreach to these patients. And so this use case is very interesting because what we said was we started the threshold with a very, very high specificity, like 99.5% specificity. So when they rolled it out, actually, there were not enough alerts. Like normally we want to, we overwhelm people, but here it was like one alert every several weeks. And so what they're doing now, after they've kind of socialized this with the staff, is beginning to dial that specificity back. And then finally, Dr. Vignesh Arasu is using computer vision for mammograms. Here he compared the use of an open source algorithm called Mirai versus a clinical risk score that was developed by cohort studies, and showed that the algorithm itself could improve the risk stratification, identifying the high risk patients, where today we can only identify about 35% of incident cancers among women with a negative mammogram. Maybe they go for a screening mammogram, it's read as negative. We can only identify 35% based on traditional risk factors, but when you overlay this computer vision technology, you can increase that tremendously. And he's currently running a trial in which this is in line with clinical care. So these, again, these are building off these principles, these competencies, and hopefully a pipeline that we've established. Okay, let's go into the final part of this talk. I think I've talked about the fact that I think the principles of our care, which is effective risk stratification, proactive outreach, and then aligning that with the right venue of care, is still the same. What's changing is the capability of this computer center. So we have seen AI this year show human level skill. Well, even prior to this year, it showed human or superhuman level skill in some applications like video games and board games and other things, translation. But it did well on the USMLE. It would get a Wharton MBA. It outperforms 85% of the 4 million programmers assessed on Python on LinkedIn. I think that was like GPT-3, right? So that's already like ancient history. GPT-4 exceeded that performance. So this is hard to see, but this green circle is the performance of GPT-3. This is the performance of GPT-4. And compared to human test takers on the GRE, the SAT, the bar exam, the math portion of the SAT, the LSAT, the AP bio, AP stats, and showing that it's, capable across all of these. So making impressive strides. And then we've seen it do really fantastic things, like if you ask it to say, give me a selfie from the Stone Age, it produces this, which I'm pretty sure, well, I don't know. There may be some amazing artists out here. I'm pretty sure I could not do this in any way. And then there's even these fantastic stories. This is from Sebastian Bubeck at Microsoft, where he kind of woke up one night and he said, let me give ChatGPT something that's really, really challenging. So he said, I want you to, and there was no graphical portion of ChatGPT. It was all text-based, but I want you to draw a picture of a unicorn, but only through code, right? So like, that's pretty challenging. And it output code. And he said it was also in kind of some computer language that wasn't used very frequently. And what it did is it output this code here to the left, right? With that as it's being its only prompt. What they then said is over time, as the technology continued to improve, they got to something like this. So again, fairly amazing, because if, even for programmers, if you ask them to sit down and make this image, like they certainly could do it, but it would take some time, and this did it very rapidly. So as we approach this question about will machines become more intelligent than humans, I think there's a lot of active debate about when and if this will happen. There's some really nice writing about this from Nick Bostrom. There's Superintelligence by Nick Bostrom. There's a book called Life 3.0 by Max Tegmark. So for those of you interested in what the scenarios look like if that were to happen, I would recommend you read those books. But I think we're clearly seeing that that the capabilities across a breadth of competencies exceeds probably what any human could do today in these kind of standardized and more systematic kind of queries. As we've begun to think about it, it's really thrown our competencies into question, because how do you test the performance of a large language model? Or how does one integrate it into EHR? There's a lot of activity. I know here there's a lot of activity with Epic. How do we assess model bias and fairness? How do we think about model intelligibility? There's a lot going on in the risk regulatory space. How do we maintain such a thing, and how do we upskill our workforce? So we've begun to do some of this work in this new age of AI, but I would say a lot of it's very exploratory, and I'll kind of just finish with some of these examples. So Dr. Chris Lee is our oversees virtual medicine for our health system. And so what they did was they built NLP and a large, like a less advanced version of a large language model using transformers to intercept physician secure messages from patients, right? So this is the overwhelming flood of messages that patients are sending their clinicians. Intercept it before it got to their intended physician inbox, ran it through a labeler, which would kind of break it down into the topics. And then with those labeled messages, shunt them to a regional workforce that would respond to the message before it ever arrived in the doctor's inbox. And where possible, they would just resolve it. So this could be easy things like, what time does the pharmacy open? Or please refill my medication. Or any of these topics here. So there's about 30 labels. You can see there's asthma, administrative tasks, blood pressure, COVID, controlled substance, diarrhea. Emergent here in red means it was flagged as having worrisome symptoms, and they wanted to get a clinical expedited review, because clinicians might take as long as 48 or 72 hours to make it to their inbox. And what they found was that in a 5-month period, patients sent physicians, just family internal medicine or family medicine and pediatrics, 4.5 million messages. And this system, where we paired together this kind of AI with, again, this regional response, we were able to resolve 1.5 million messages without ever reaching the physician inbox. So that's incredible, but also still not enough, because that still meant 2/3 of the messages still were going to physician inbox. So there's still a lot of work to be done there. What we published here and will be forthcoming is the composition proportion of all these message labels across these messages. In order to, I think, and what becomes apparent when you look at this is that message content is extraordinarily stable over time, right? So instead of each physician trying to respond to this entire spectrum every week, well, why not have a systematic way to say, 25% of the time we should be shunting these medication questions to pharmacists if they're appropriate, right? If it has to do with maybe a new medication, maybe that's not appropriate. But instead of thinking about each physician having to be in charge of this, we should have regional inboxes that really deal with erectile dysfunction or skin conditions on a routine basis. We're likely to make our patients more satisfied because we can turn these things around quicker and hopefully make our clinicians more satisfied as well. Another recent example we just published, I think a couple weeks ago. Aaron Tierney is a fellow of ours, and we implemented Nabla Copilot, which is an ambient AI. So essentially what it does is you use your smartphone while a patient and physician are talking, and it records everything that they're saying, and then it puts that into a transcript, and then it summarizes it. So you can reduce the clerical burden of documentation. So because of the kind of overwhelming burden of documentation, our leadership was really interested in rolling this out quickly. Here we used 10 weeks of data since go live. About 3,400 of our clinicians had used it. And in total, they had used it in 300,000 visits in just 10 weeks to help reduce that burden of clinical documentation. Here we looked at was the use of this associated with decreases in time spent in the chart. And so here we use something called difference in difference analysis. So we looked at the decrease in time spent in notes among those who did not use versus those who did use. And then we took the relative difference. And so we did find, actually, I was surprised. I thought we would not find any difference, but we did find a significant decrease, larger decrease in time and notes per appointment among users. We didn't find any decrease in time in clinical review, in baskets or orders, and we would not expect to see any difference because those were not the subjects of this technology. We also examined the note based on a bunch of quality metrics like free from hallucination, organized, comprehensible, et cetera. And we did a review of 45 notes and really kind of graded them by each of these domains to try to see if the quality of the notes was good. So again, pretty an initial exploratory approach to, as we shift into this new age where the computer center is becoming far more capable than what we even believed was possible 5 years ago. Thinking through what are the structures we need in place, what are the competencies and the approaches we need to execute. So I talked a little bit about bias, so standardized macros for evaluating bias across these potential dimensions. Again, this is another model of ours where we predict how likely a patient is to go to a SNF, a subacute nursing facility, on hospital discharge. Also, this is the documentation, the clinician education FAQ about our suicide risk score. And it gives responses to like, what should I do if the Tritium critical suicidal ideation alert is high, but the risk score is low? And Tritium is a patient-reported outcome app. So, kind of like questions that would very reasonably come up by clinicians, if we get discordance in kind of the scores, also kind of like different approaches. It talks about patient surveys and their responses to how they would like to be valued and approached. And then we're funded by the Moore Foundation to stand up a program to fund 5 external health systems to deploy AI in the real world and then to do rigorous evaluation. It's a program called Aim High. We recently announced our 5 winners. Two of them are deploying AI at federally qualified health centers. So, in underserved populations, that's in Texas and near San Diego. And then the other ones will be computer vision of cardiac amyloid and echoes, a clinical trial of precision resuscitation in sepsis, and then looking at venous thromboembolus and algorithm of vigilance. And then finally, we're keeping track of the regulatory landscape, which is getting super complicated and very difficult to manage. Here, last year, I pulled out some of the principles that were described by the White House, the WHO, the EU, and NIST about AI. AI should do no harm. It should be safe. The design should include diverse stakeholders. Humans should remain in the loop. Data privacy should be preserved. And we're going to see more and more guidelines and guidance, especially as the executive order is, they just passed the 90 days after the executive order. So there's a lot of milestones and landmarks that they are going to need to meet. And finally, these are fellows in the informatics program that I lead. There's some MDs, there's PhDs, there's nurses, pharmacists who are all using these types of informatics strategies to tackle high-impact health system problems. So I'll end with just two quotes. Morris Collin, the founder of the Division of Research, said, "The computer will probably have the greatest impact on medical science since the invention of the microscope." And Stephen Hawking, speaking on AI, said, "Our future is a race between the growing power of technology and the wisdom with which we use it." I want to thank many, many, many folks across our institution, and this is an older slide, so there's even more who participate in this work and who really, I get the pleasure and opportunity to highlight and profile their work. And thank you very much for your time.
Great, thank you for that excellent talk on I think a really timely topic for us. So I'm going to open it up for questions. We'll focus somewhat on the online questions, but as a reminder, you can also come up to talk to Dr. Liu at the end at 9 o'clock to 9:30. So it looks like we have some questions for you. All right, the first question is, did the Mycin study take into account allergies, co-prescribed pharmacokinetic issues, costs, pills per day, et cetera?
Yes to a bunch of the ones that were listed first. I don't know if it looked at cost, but what they found from Mycin, another challenge, and we talked to you, Matt, you mentioned this yesterday. I mean, that was one age of AI, which is expert systems or these rule-based systems. The problem is you need so many rules to encode knowledge, and then you need to keep updating them because as new studies come out, that the workforce to do that and do it effectively becomes overwhelming.
The next question is, when the clinician feels that the computer isn't right, will the bureaucracy rigidity prevent or inhibit taking correctional steps?
Correctional steps in terms of the score or the patient?
Or the clinician. I don't know.
So the thing that and I'd love to hear your experience, but the thing that I love is that people there's a group of folks who really do not like our early warning score. They think it's wrong, they disagree with it. And I think what that shows is, I mean, first of all, those of us who work in this space know that not every the scores are not perfect, they're not even close. They generally have more false positives than they have true positives. But that's a lot of how we practice medicine, right? We say, we'll give this pill to someone then 300, and of 300 people we give it to, one person will have a benefit. So that's not new to the way that we practice. But I love when I hear feedback like that because one, it highlights opportunities for us to improve the models, but two, it shows clinicians are being clinicians. Do you know what I mean? If they disagree with an alert, they should choose to do what makes sense for them at the bedside. And so we do look at metrics of folks who don't follow, a specific recommendation. We don't actually provide a specific recommendation. The recommendation is go eyeball this patient and make a clinical determination. But I think we need to allow for the fact that there are inaccuracies in this, and a clinician should be empowered to be a human expert and do what they think is right.
The last online question is how can clinicians, wait, is it the top one? Sorry. Oh, I see. Yeah. So I guess what are some of the best ways that clinicians can learn more about AI, and how can you find mentorship in the field or to get involved in whether it's the operational or research side related to AI medicine?
Well, I think you can talk to Matt. You can talk to your informatics leadership here. I think that there are a lot of opportunities because we don't yet know how actually to measure and evaluate something like an LLM in practice. And I think it's gonna depend on probably at least 3 factors. One is the vendors who supply them have to be able to supply some kind of dashboard that shows us their technical performance, because that's the obligation, right? If you have purchased a car, the car manufacturer has some obligation to you, like a wiring diagram, and to send you updates or not send you, but recalls if they identify a manufacturing problem. So one is to make sure that we push back on vendors to say you need to do more than just provide this product. A second, which is challenging, but where people can definitely get engaged, is user feedback, right? Which is either analyzing the output of these tools and comparing them to what you would write or think is reasonable, and then being empowered and engaged through hopefully very simple ways to provide that feedback or to do reviews in the same way we do quality reviews of, sometimes of programs or other care that we provide. And then I think the third way is AI versus AI. Like, unfortunately, we rigorously looked at 45 notes, but the tool had been used in 300,000 instances. There's no way with the scale that these tools can be deployed, we could actually expertly review. And so there's a bit of a lack of understanding about whether we've reviewed the notes. Like, if you randomly picked out 45, would you have even picked up the ones in which there were bigger gaps? So Peter Lee at Microsoft has kind of said, there are times when AI, like a ChatGPT, will get something wrong, but what it does really well is when then you feed that output into itself, into another ChatGPT, it actually identifies the errors very, very well. So I think we have to also be thinking about how we stack these technologies kind of in series and leverage some of that, its own kind of self-check.
Questions from the in-person audience?
Thank you for a wonderful overview. And I think the potential here is huge. One question I have is, in your matrix, when you're at the very bottom, you're talking about workforce upskilling. Is there any information out there to suggest that when you've got a human and a brain and a computer, and sharing kind of decision making, at some point there could be a downskilling of the workforce as far as the influence of provider learning and provider behavior when interfacing with such a system?
Yeah, I think that's a really good question, and I think that, I mean, for us, that's why I like that. Even with these less advanced kind of models that we deploy, that clinicians show they're still thinking. But I think the risk, and the thing that's called out in the FDA regulation, is this concern about automation bias, which is that if you become so comfortable with something that you will give all of that decision-making agency to the computer and essentially just become like clicking it through, or if it's like even fully autonomous, like you would not even be involved. So I think that is a hugely important area where clinicians need to really stay engaged and come up with systems for how we combat that. I do think there are tasks that we will give up. Like a third of some of the tasks we do, maybe as much as a third, don't really require our best attention. And those would be potentially easy to hand off to a well-performing algorithm with oversight. But what it will do is then replace that third with even more, hopefully, advanced and higher order thinking that is demanded. You know what I mean? Like, I don't know, I'm not an oncologist, or let's just use a case example in critical care, ventilator management. There are definitely scenarios in which they're very complicated, but a large portion of them could probably be a system that is kind of autonomously managing the vent. And people have been working on this for a while and alerting us with the concerns, allowing us to then focus on other dimensions of the critical care patient's trajectory, right? So, I think that's part of the upskilling. But we do have to be really vigilant to not cede our agency and authority to machines. I do think we need things like kill switches. We need downtime protocols. Like, do you know what I mean? Like all of these things which we might have with the EHR today, which we usually don't use, but in the case that there's like a misalignment, we have to be prepared to take back control and be able to identify where we're kind of diverging.
Thank you so much. That was a very interesting talk. And I was looking at the imperative to keep the humans involved and how you've talked about that. So there's a parallel part to that, which is satisfaction and wellness on the part of the clinicians. And I'm thinking of that while you mentioned perhaps dividing all of the phone calls that come into my clinic into categories. And I would not want to be the dizziness doctor for the day answering those phone calls. So when you talk about subdividing, I don't know how that would help physician satisfaction. But in the bigger picture, I think there's that parallel satisfaction and wellness, and how I'm curious how that fits into your algorithms or your studies and how you improve systems.
Yeah, I mean, I would say, so let's use the ambient AI as an example. The feedback we got, and the reason we went quickly is because the initial pilot went really well, and the feedback was very useful. But we are at a bit of a diffusion of technology. There's kind of like that, gosh, who's the author? But there's the early adopters, and then you get to the late adopters, and then you get to the kind of folks who will never adopt. And we're at a little bit of that plateau, which I think highlights that just like any new technology, we have to balance kind of those folks who really are engaged and adopt it versus those who don't. And then as to the question about like regional versus local practice, and would I want to live my life as the dizziness doctor? I think that's kind of a broader question. Do you know what I mean? It's like, do I have to take night call once a month? It's kind of like maybe one of those things that you do as part of kind of for the good of all, or it's distributed. But you're right. Like, we have to fit people to the roles that I think they're going to maintain satisfaction in. But I know that many doctors are unsatisfied with their inbox, right? So a solution is needed for that. It may create some other downstream challenges.
Great. So I think we're a bit over 9 o'clock here. So I just want to thank Dr. Liu again, and just a reminder that everyone can come up and talk to him for the next 30 minutes. So thanks again for a great talk.
Thank you.